So I'm going to talk about something that I think is not so commonly talked about, because all of us want to talk about surgeries that we do and how cool we are. And I realized that I actually lucked out better with my patients when I started thinking a little bit more in depth about what the disease pathology driving the sinusitis was. So when I had to decide about all the talks that I had given and what I would like to share in essentially my alma mater, I spent a whole year in 2009 to 2010 with Dr. Huang. So what is it that I learned in that time period that I could come back and share? And it's about how we could use subtyping in chronic sinusitis patients in an effort to optimize the outcomes. I have no disclosures. These are two Mayo brothers who set up their clinic over about 155 years ago in a small little town in a cornfield. And Will and Charlie established this clinic, which is a large operation in Mayo Clinic in Rochester. I actually come from one of the outposts, which is actually in Arizona. They label it Scottsdale. The main hospital is actually in Phoenix. And we have three what they term as destination medical centers, which is basically designed to cater to the needs of referrals from all over the country or from abroad. We have three shields, the largest shield being patient care, and the primary mission of Mayo Clinic is that the needs of the patients come first. And the two other shields represent research and education, and it is our philosophy that both go along in actually advancing patient care. And much of our, I see Dr. Most, hi Dr. Most, that these are all tied together. So we don't have the capability to do basic research like you all do here at Stanford, but we actually try to do our best with translational research. So my home, Mayo Clinic in Arizona, is about 30 years old. We helped contribute to seeing about 1.5 million patients from all countries over the globe and from all states of the United States. We're a busy hospital, and this year our Board of Governors approved a $700 million project to basically double up our capacity. We're nowhere close to you. We'll go to some 350 beds for inpatient care. This is my tiny office, and I proudly hang my Stanford degree from my instructor year. And you can see Jane and Dr. Huang peeking out behind in there. So, but hopefully with the expansion, I was hoping for a bigger office, but I think we'll have shared spaces like Google. That's the plan. I'm hoping that they'll have beer pong and all of it too. So, having said that, I am actually very much a progeny of Stanford, and a lot of what I know now is thanks to my mentors here, Dr. Huang and Dr. Nayak. And I've taken that to Mayo, and we've grown a good program there. So a little bit about Mayo Clinic in Phoenix. As I said, it's a small operation, but we are right there behind you in terms of being one of the best hospitals in the United States at number 11. And it is our hope and goal to actually move closer and displace this unknown entity up top called Mayo in Rochester. So we'll see. So I hope that when I finish up this talk, I'll be able to explain to you, and you'll be able to explain why subtyping chronic rhinosinusitis can be advantageous, not only from a research perspective, but also to our patients, and sort of differentiate between what's a phenotype and endotype, and then enumerate some tools that we can use to endotype, and more about all of those. Sinusitis is a very common diagnosis, and we think that about 30 million people that comprise about 16% think that they have sinusitis or report that they have sinusitis. If you look at actual physician reports and studies that have looked at that, probably, the percentage of true CRS patients is about 3%. And most of them do actually quite well with treatment that we institute for them. This is a paper that I selected. It's over 20 years old and comes from Jim Stankiewicz, one of my other mentors I hugely owe my professional career to. And what Dr. Stankiewicz said is that The vast majority of patients will actually do really well with endoscopic sinus surgery, but there is a percentage of patients that will fail. And what he said, one must be on the lookout for the recalcitrant patient who may have other medical problems complicating his or her sinus disease. Guides to management of the primary functional endoscopic sinus surgery failures are lacking in the literature. These patients must be addressed by isolating the problem areas preoperatively with both clinical and radiographic findings. And so that was 20 years ago, and now subtyping has suddenly become mainstream. There are many reasons why patients get recalcitrant disease. They could have a disease subtype that is just very, very aggressive. It's even well thought out medical treatment for them may be ineffective. Some of them actually suffer from inadequate surgery. And some patients just are not invested enough in their care to actually get going in terms of improvement from the sinus surgery. And most often it's just an unfortunate melding of circumstances that leads to these problems. But when sinusitis becomes problematic, it becomes really problematic. And this recent paper, which was published, estimated that we spend about $60 to $65 billion annually in the United States. And this is about 5% of our overall healthcare expenditure, which is now up to 20% of our GDP. And this is not a pathway we can continue to sustain or support as a society. And there are even higher costs and indirect expenses. Disability patients report more problems with sinusitis than they do with back pain or chronic angina. So it is a big problem. What is problematic sinusitis? I think we could term it as sinusitis that's either recalcitrant, uncontrolled, or difficult to treat. And there are attempts that have been made to define what we could call a difficult to treat patient of rhinosinusitis. And these are patients who have persistent and significant symptoms in spite of appropriate treatment. And the key word here is appropriate treatment. And these patients don't get to an acceptable level of control. And the EPOS document, which came from Europe from Dr. Hawkins and Lund, had a arbitrary criteria of saying that if they had received 2 short courses of antibiotics or systemic steroids in the past year and still had recalcitrant problems, then they were difficult to treat. I think in my practice, this is what I say to my patients. If you're going to require 3 or more rounds of systemic oral steroids or multiple rounds of antibiotics, then I think you have difficult to treat recalcitrant disease. You may be in the subset that's going to require another round of surgery or more advanced medical treatment. Chronic rhinosinusitis, which is not responsive to conventional treatment, which with our academy guidelines, with society guidelines, and the highest data is for intranasal steroids and saline irrigations. And in some situations like chronic sinusitis with polyps, oral steroids. If these patients are not responsive to the usual, then they can be considered to be recalcitrant. And what the EPOS document said is that it would be helpful to accurately subtype CRS at the onset, utilizing clinical cues and lab tests to follow, since some of these subtypes may be very difficult to manage. So they talk about doing it at the outset, not when your treatments are failing. So why do I think that subtyping is essential and a necessary component of initial patient care? Is because we know that our patients have chronic rhinosinusitis not because of one factor. Most of them we are unable to identify factors, but there are other factors we know of: autoimmunity, immunodeficiency, allergies, infections, congenital problems, genetic unrecognized factors that we don't know. And it's unlikely that we have the silver bullet that we can deploy that will treat all of these conditions that might be underlying. So I think it's important to have a nuanced approach. In my opinion, every patient is unique in the inflammatory profile, which is based on the genetics, the genetic predisposition, the environment they live in, the treatment that they have received, antibiotic exposures in childhood, smoking exposure in childhood, and I think they deserve to be assessed individually. And so I believe that the optimal management of these patients requires a very personalized and customized approach. And it's my belief that this will lead us closer to success for many of our recalcitrant patients. So what is subtyping? Basically, there are two concepts: a phenotype, which is something that you can observe, and an endotype, which basically utilizes some biological markers. And the presence of or absence of those biological markers help us endotype these patients. And what we're trying to do with these biological markers is to pinpoint specific pathophysiologic mechanisms that might be in play within these patients. So, everyone recognize this lady?
Michelle.
Someone who doesn't?
Michelle Pfeiffer.
Michelle Pfeiffer, I love it. So, what's a phenotype? I mean, you could say, yeah, you know, Michelle Pfeiffer looks very much like Devyani Lal. I mean, we have the same phenotype, you know, long hair, beautiful, tall, blah, blah, blah.
Oh, no, that's
Okay, you just endotyped, right? No, okay. So anyways, so an endotype is her BRCA mutation. She is a BRCA mutation positive endotype, right? That's an endotype. So phenotypes are easily observable. Endotypes, you have to look with biological markers. So our society's academy has classified chronic rhinosinusitis into two basic phenotypes. If you observe polyps, there are patients with polyps, and if you don't see them, they are CRS without nasal polyps. Endotyping, on the other hand, can be used, you can use a variety of biomarkers to do so. You can use cytokines, any metabolic pathway chemical that you are interested in, gene analysis, genotypic expressions, microbiome, etc. So based on that, you would classify that as an endotype. However, right now, as we stand, our therapy guidelines are basically devised by phenotypes. And the three most recent guidelines are from our academy, then one from the ARS, the International Consensus Statement, for which Dr. Wang was a prominent co-author, and then the EPOS guidelines from the Europeans that I talked about earlier. And what these guidelines assume is there's an assumption or a presumption of endotype based on phenotypical features, and for most they may be fairly accurate. So if patients have polyps, we assume that in the United States, in the Caucasian population, they will actually have lots of tissue eosinophilia, and the interleukin-5 will be elevated. And those patients without polyps, there'll be low tissue eosinophilia and IL-5. And in parts of the world, in Asia, this does not hold true. Those patients have neutrophilic polyps, and as they undergo urbanization, they actually start moving towards more eosinophilic polyps. So there are papers that were written, this one I think is from 2013, where they said, this is a European paper, said polyps, no polyps, and they sort of classified what sort of, endotypes would be based on some other additional features like aspirin sensitivity, etc. And they basically, drove down to two basic subtypes, where it says that if you have tissue eosinophilia, it's a Th2 inflammatory pathway, and all these allergic fungal sinusitis, aspirin sensitivity, IL-5 activity, IL-32 activity would be high. And in patients that didn't have eosinophilia but had tissue neutrophilia, they would have more fibrosis, TGF-beta, and other factors that they speculated about. And based on some of these assumptions, we have guidelines, and I put this because this puts, the EPOS document puts it nicely in a simple fashion, say, in patients without polyps, the highest level of evidence supports the use of topical nasal steroids and saline nasal irrigations. Everything else, we really don't know. In patients with polyps, again, topical steroids and oral steroids have the highest level of evidence. And that is all good, and our only Nobel Prize for Mayo Clinic came in 1950, not like you all, I counted I think 7 walking around, and this came for oral steroids. So don't get me wrong, we are happy to have contributed this into the care of humanity, but does it always work, right? And so when we start looking at the evidence, when we start evaluating outcomes for our patients, we really don't know what we are doing in really recalcitrant patients with the use of these medications. So why does this all matter? If we look at the truly recalcitrant patients, and this is a recent review that Amar Miglani, who spent some time with you a couple of weeks ago, did, and it's now published in IFAR. If you look at the revision rates across from 1993 to 2017, you look at the revision rates being fairly high, up to about 27%, and some subtypes it's even higher. This paper looked at 5-year revision rates in patients with polyps. And if you had polyps and aspirin-sensitive respiratory disease, then you had a revision rate of almost 40%. 40%, that's almost half your patients. If you had polyps and asthma but no aspirin sensitivity, a quarter of your patients are going to have revision within 5 years. CRS without asthma or ARD, better. If they had polyps without those, they reported 10%. If they had really severe disease, and this comes in from Rhoda Wynn's paper, 50% were advised to undergo revision surgery, and about 30% actually underwent revision surgery, and this was in just over 3 years. This is again another recent paper that had about a 5-year follow-up. And what they found is that asthma advanced CT stage did not predict time to recurrence. So that didn't mean that if you had massive polyps and you were naturally predicated to have revision surgery. What they did find is that if you were a smoker or had smoking exposure, it would mean that you were more likely to require revision surgery in that short period of time. They also reported that if you resected the middle turbinate, there was actually a lengthening of time to revision surgery. And I'll come back to that point because I don't necessarily agree with that point for an overall predication. Aspirin-exacerbated respiratory disease is probably known as a very severe form of disease where 40 to 80% have been reported to require revision surgery. So the problem is, I think, that when we look at the guidelines from our academy, there is not as much value placed in the guidelines on subtyping disease. And this extends to subtypes that we actually know a lot about. And these include allergic fungal sinusitis, AERD, cystic fibrosis, a variety of other newer factors that we are discovering now about vitamin D deficiency, etc. So I'd be fine if the academy said that, oh, we really don't have much data about them, but I would really like for the academy to say that there must be an intent to subtype these patients, and that's why I think that we should focus. We know that as we know more about these patients, we have more sophisticated tests, etc., that we can actually continue to characterize more and more disease. This is a disease process, IgG4-related disease, that I became familiar with when I was referred a patient from a very good rhinologist who was struggling, and the patient had 3 operations. And then at the same time, by chance, I had another patient who would have lymph nodes and chronic sinusitis, would respond really beautifully to oral steroids, and we biopsied him multiple times, couldn't diagnose lymphoma, couldn't tell what it was, and then he got pancreatitis, and the GI guy told us that it was actually a disease condition called IgG4-related disease. It's a newly defined condition. Affects all body systems that have exocrine glands. Head and neck is actually the second most common, and all those diseases like Kuetner's disease and Riedel's thyroiditis, they are actually IgG4-related disease. And these patients, if you recognize them, they actually respond very well to oral steroids, but long-term they do very well on simple immunosuppressants like methotrexate if you get your rheumatologist involved in it. So just something to think about. And this is another paper that I found interesting because they talk about central compartment atopic disease where you see polyps, but they're more in the middle part of the nose rather than in the periphery as you would see with allergic fungal sinusitis or aspirin-sensitive disease. And I think these are the patients that are highly atopic. They have asthma, and they're quite easy to diagnose, and the prognostication is, I think, much better than the patients that have severe lateral disease. So I think that clinicians could subtype many CRS patients just based on simple things like history, endoscopy, CAT scans, cultures. These are all available to us. Finding out if they have asthma, bronchitis, bronchiectasis, smoking history, allergy and immune evaluation, and simple serology like CBC could tell us things like eosinophilia. What is the level of IgE? We know that this is elevated in polyps with or without allergies, CRP, SED rates. We could talk about some of these other tests, and I think what is really lacking in our practices is support from our pathology colleagues in telling us what is it that we are dealing with when we give them surgical pathology, because if they are telling me that the patient has chronic sinusitis without evidence of malignancy, I already knew that when I sent the specimen to them. And so, my pet peeve. So, again, to reiterate, polyp, no polyp status, undervalues CRS diversity, and while for most patients, the classic pathways of Th2 polyp, Th1 or Th17 in patients without polyps might hold, this isn't actually entirely accurate. This slide is from Professor Bachert's group. In 2014, he talked about endotypes. He does a lot of work on Staph aureus. And so he divided CRS patients into those without polyps, with polyps, and said, I'm going to divide these into endotypes based on IL-5 if they're positive or negative. And then he divided IL-5 and IL-17 types. And he has done a lot of work on Staph aureus, and his big mantra was that Staph aureus enterotoxin and immunoglobulin E to that enterotoxin was actually the cause of many of the polyps. However, when this group followed up and actually looked at a multi-centered study where they had tissue from a lot of CRS patients from across multiple centers in Europe, and they did analysis of all the cytokines that they looked for. They basically took 14 cytokines and then performed a cluster analysis. And if you look at the slide, you can see that they ended up finding 10 clusters based on these cytokines. And here you have the percentage of patients with polyps and percentage of patients with asthma. So you see polyps, asthma go very well together. No polyps, no asthma goes very well together. These are the subgroups that probably did not have Th2 inflammation. These are the subgroups that had Th2 inflammation that is associated with eosinophilia, IL-5, and all of those features. But what is interesting to me is that 40% had mixed Th1 and Th2 cytokines. And in 16% of the patients, they couldn't find any markers. So what are these patients? So we actually followed up and looked at some of our patients. This was a small study that we did with a small amount of money that was available. And we took a commercially available 41 multiplex kit and then also major basic protein, because Hiroi Takeda, who's co-author on this paper, has done a lot of work on that. And basically, the advantage of this study, even though it was small, is that we actually did not presume to test which cytokines we're going to look for, because Klaus Bachert actually didn't look for IL-13, where dupilumab or works against IL-13. So a lot of the targets that we now are looking at, IL-33, were not included in that study. So this is, I think, a more unsupervised, unbiased approach to looking at that. And long story short, what we found that while the polyp Th2 asthma connection and the no polyp and having a Th1 or Th17 association was strong, we found that mixed inflammatory patterns were extremely common. So I think that we have other studies going on trying to distill down more of these associations, because to me the group that is mixed is actually the more interesting one in terms of subtyping, because if we can kind of find more about them, then we can direct treatment that is more personalized towards them. This is another study where we actually looked at patients without polyps. And we're looking at something else. We're looking at SNOT22 and what they were like in patients without polyps and how they prognosticated, etc. And we looked at a variety of factors, including the histopathology. And what I wanted to present here is that in a third of our CRS without polyp patients, meaning that we didn't see overt polyps by nasal endoscopy, we found tissue eosinophilia. So these are the patients, if we go by the polyp, no polyp, we're not going to use any oral steroids. I mean, we're underserving these patients. And so having talked about subtyping and not very surgically exciting topic, I really want to distill down to this question. As a surgeon, why does any of this subtyping matter to us? And this is some of the results that we just published. Actually, Amar got the best poster award at the Academy meeting. And our reviewers had some concerns about calling it an endotype-directed therapeutic approach. And so we had to revise this title to Revision Endoscopic Sinus Surgery Rates by Chronic Rhinosinusitis Subtypes. Short word, actually we're number 28. You guys are number 2. We've got a long ways to go. Okay, so we took 424 patients that had undergone surgery with me, and we had quite a big number of CRS with polyp patients, 170. And we looked at the revision rates. We looked at a bunch of things, but this slide shows what our revision rates was. And a median follow-up was almost 4 years. So if you look at the revision surgery rate, we reoperated on 19 patients. That's a 4% revision rate. And our revision rate in polyp patients was actually lower than non-polyp patients, so 3.5% in that. And anytime I say that at a meeting, people just, stand up and, there's a visible reaction, because if you look at the rate of what's published in the literature, we talked about it in the other slide. If you look at that, the rates of polyp revision is, in some series, 30%, 50%, or 80%. So I think there's room there, and it's not just that, okay, we do meticulous surgery. I think a large part of that is subtyping and subtype-directed medical treatment. And if you look at the improvement, now one of the criticisms one could say is that your revision rate is determined by 2 things. A, did you advise your patient to have a revision? And B, did your patient agree to have a revision, right? But we looked at the SNOT-22 scores of these patients as well. And you can see, as we look in here, that the SNOT-22 scores in these have significantly gone down from the preoperative SNOT-22 score. So they had very meaningful differences. And even when they were undergoing revision sinus surgery, the SNOT-22 scores were actually far lower than where they started out. And most of these revisions are probably directed by me, because I was worried about something scarring down or polyps recurring, etc. So if you look at the revision surgery of all the cohorts together, and if we compare that first slide that I'd shown a few minutes ago, 37% for AERD patients, and we look at our AERD revision rates, we actually have 2% revision rates for AERD. In fact, when I see AERD patients, I'm happy, because we do surgery and we put them on anti-leukotriene treatment and we put them on aspirin desensitization, and they are the least problematic subset of my patients. I struggle with people that I do not characterize. And if you look at the people we were able to characterize, that was only 30%, but we made progress with those patients. So our revision rates were highest in patients with GPA or Wegener's granulomatosis, or those patients with immunodeficiency. So in terms of polyp patients, we did much better. EGPA is eosinophilic granulomatosis with polyangiitis or Churg-Strauss vasculitis. So our approach is doing a very thorough history, clinical examination, and then using history and clinical examination to give us clinical cues to actually direct testing. We don't do all tests on every patient. We try to see if we can recognize a pattern and a subtype, and if that is recognized, we direct treatment towards that. I think a good history is invaluable, and I'm sure all of you will agree that many of our patients that complain of coughing actually have asthma and they've never been tested. Patients don't know whether they have aspirin sensitivity because they've been told, some of them, never to have aspirin. And we can gather a lot of good information from history. This is a patient that was referred to me because the referring physician had done 3 procedures and noted everything was scarring down, and this prompted an evaluation for Wegener's granulomatosis. Biopsy did actually prove that. Some signs are more subtle. This is nodularity in a patient who was actually having coughing and shortness of breath. And if you look at the chest x-ray, they have classic findings of sarcoidosis or ACE positive. And in these patients, sometimes you can find some subtle depressions on the nasal bone. So if you look at a CAT scan like this, in a patient who's had surgery or not had surgery and see a lot of dense osteitis that looks really, really remarkable, think Wegener's disease. There are a lot of clinical cues instead of making the mistake, because your pathologist may or may not be able to identify vasculitis and necrotizing vasculitis. In 40% of the patients, we will be able to recognize it, and 60% they will not find anything. So it's important to know that. If I see a patient with pansinusitis and they have history of pneumonias, otitis media, they have pus in the sinuses, they get a really, really thorough immunodeficiency workup. So the question I have here for anyone who wants to take this question, or maybe you don't, I can answer this myself. You look at this patient who's been referred to you, and you can see all these heterogeneous densities, pansinusitis, and then really dense disease over there, and you have allergic mucin-like material that you're suctioning out. What is this disease? Obviously, this is an adult cystic fibrosis, no family history. Could be if they were a young adult. Could this be allergic fungal sinusitis? Yes. AERD. Alert. Right? Okay. Scherk-Strauss vasculitis, EGPA, polyps, eosinophilia, sinusitis, could be, right? How are we going to differentiate between them, right? It could be any one of them. So all of these conditions are associated with eosinophil polyps. They may all have allergic mucin. They may all have asthma. The serum Ig, eosinophils, all may be elevated, and many of these patients actually have mixed pictures. So I have several AERD patients where they fulfill criteria for allergic fungal sinusitis. I have several patients with polyps that have no evidence of type 1 hypersensitivity and several that do, but have aspirin-sensitive disease as well. So I think it's important to direct testing in a lot of these patients because that could have multiple inflammatory pathways to the disease. And we always ask patients whether they have aspirin sensitivity, but many of them say, I've never had a problem. Some of them have not been on aspirin for years. Some of them are actually on leukotriene inhibitors. You need to take them off leukotriene inhibitors to see if they'll actually react. So we have to do a little bit more thorough digging around for these patients. One of the tests that we do, especially for younger patients that present with polyps, if they are in the early 20s or the teens, we always do aspirin provocation testing to look for leukotriene pathways inflammation. Another test is the urinary LTE4 level. So for the residents, aspirin-sensitive disease is not an allergy to aspirin. Basically, these patients are manifesting a high degree of inflammatory pathways from overactivity of certain leukotrienes. And if you ingest aspirin, it blocks prostaglandin production, and so you have an overflow of leukotrienes, and that exacerbates nasal congestion, asthma. They may end up in the ER with life-threatening problems with breathing. So we use urinary leukotriene E4 levels quite routinely in patients we are suspicious of, and we publish on this. It's available for you to look at, and it's a clinically available test. So this is a network that shows how we, sort of our thought process of how we look for, how based on history we look for testing, and I will talk a little bit more about what are the common tests that we use. So commonly, I think in patients, I will look for a CBC in patients with polyps. You'll be surprised how many of them have not had a CBC, and just look for eosinophilia. Level of serum IgE. Cultures if there's pus, allergic mucin. Skin allergy testing if indicated. And also in patients we are highly suspicious of that might have AFS, we'll actually look for specific IgEs and IgG to Aspergillus, which may not show up on skin allergy testing. We'll also do ANCA testing for patients we suspect Scherk-Strauss vasculitis in. A lot has been written about vitamin D and poor control of asthma and polyps, so we look for that as well if they are struggling to be managed. And in specific patients, based on the history and the demographics, we'll do aspirin challenges, look for immunodeficiency workup, potentially do a cystic fibrosis testing to look for rarer mutations, quite apart from the common delta 502 mutation, and also look for other factors like SED rate, CRP, which may actually point to autoimmune processes that we may not have identified. An office biopsy is rarely indicated in my practice unless we're suspecting a vasculitis like Wegener's or Scherk-Strauss vasculitis. I will sometimes review and repeat a biopsy if they're having a flare-up, because even with patients that may have very overt features, very highly suggestive of vasculitis, they may not actually have a positive biopsy. We get a structured histopathology report, and we've been getting that since 2013, and this is based on a publication that comes from Australia, and that's a fairly detailed report that we use. So these are two patients that had nasal polyps. So patient 1, eosinophil counts in the tissue greater than 100 per high bar field. Normally you want to see less than 5 per high bar field. Patient 2, less than 10 per high bar field, also has focal neutrophilic infiltration, right? I mean, I don't even want to know anything else. At that point of time, I know that this patient is going to require long-term management with budesonide irrigations. This patient may not respond very well to budesonide irrigations, but potentially I'm going to look at the cultures, look for staph, put them on long-term macrolides, doxycycline, particularly if their IgE level is low. So there's a lot of good information to be obtained from a structured histopathology report. So how do we use all this information? This is a very simplified diagram. So pretty much most patients will get some form of intranasal steroids and saline irrigations. We do subtyping, and as indicated, talked about, we'll do all of these tests. So ANCA positive, biopsy positive, if we are lucky enough to get those, or if they have a high number of eosinophils in there and meet the criteria for EGP or Church-Ross vasculitis, they go to the rheumatologist, and these are all recalcitrant refractory patients. But we have identified them, and if they don't respond to the usual surgery, oral steroids, budesonide irrigations, there is room for these patients to go on immunosuppressants and do well long-term. IgE levels, we use that to prognosticate whether these patients are going to respond to long-term macrolides, long-term doxycycline. If they have low IgE and they're not responsive to nasal steroids, etc., I'll put them on those long-term medications. If they continue to have super high IgE levels, we had one veteran that had returned from Iraq and after surgery continued to require 60 milligrams of prednisone a day and an IgE level of 13,000.
Wow.
He got put on omalizumab, and I see him every year. Just looks pristine. Worked. Doesn't work in anyone, but I think that that's what we need to do, is to subtype these patients. If they have selective immunoglobulin 4 deficiencies and they're having recurrent exacerbations, infusions may be indicated. If they have positive staph enterotoxin, long-term medications directed towards staph like doxycycline might be helpful. We talked about LTE4 levels and how we use that, putting them on a montelukast, and if they don't respond to montelukast, which is a leukotriene receptor antagonist, going to a leukotriene synthetase blocker might be helpful in these patients. And then culture-directed antibiotics, and in very few select patients where the usual first-line medications have failed, potentially treating them with oral antifungal agents. And I talked about how we used our histopathology. I think the important part, I tell my patients that surgery lays the foundation for good medical treatment. I don't think I can make you better without surgery, but I don't think I can make you better without medical treatment after surgery. So to me, surgery is an architectural change for the patient. It also removes polyps and disease, but it lays the foundation for lifelong medical treatment. I told them, you got to decide if you want to see me for the rest of your life or my life, and that's when we'll undertake surgery, because polyp patients and scored patients and this patient, they'll have a different sort of approach. I mean, you cannot do the same operation just because you have seen them for the first time and this is your way of doing primary sinus surgery, revision sinus surgery. So I think surgery, in my practice, I base it on what kind of disease subtype they have, the objective disease burden, and the subjective disease burden. And I think that many of us, when we are sitting on panels in national meeting, that patient-centered approach to a quality of life disease is lost. It's what I do. What did the patient want? Nobody talks about that. So, so this is a patient that I'm going to share with where I will, for a primary case, I'm going to do full house FES. I don't do a modified Lothrop. This is, if you can see, there's extensive bony expansion. You can see a sagittal view, all eroded and expanded. We look in there, there's polyps and allergic mucin. So in patients that have nasal polyps, I don't talk about minimal surgery at all. I do full house maximal surgery. I have a very small threshold for doing septoplasty, and Tim Smith's group wrote about it when they looked at surgeon-specific outcomes. And the only difference that they found in outcomes for patients, if you did a septoplasty, it actually made a difference. And I think there's several reasons. Many of us are worried whether insurance is going to pay for septoplasty. Well, my rationale, and I dictate that in my note, is yes, it'll give me access to surgery, but if I don't align the septum, how am I going to deliver post-op topical medications as part of my treatment for CRS? Management long-term. So here we are, look at that. And I've been fooled as a resident in the past and actually almost hit the nasolacrimal duct, and Dr. Wong came in and said, what you doing? So I always remember that. So this is an everted uncinate process, will happen because everything within that maxillary sinus is expanded. So this is a retrograde uncinectomy. That's how I like to do it. That's how I was trained to do it. And my goal is to still leave a port of that uncinate process up top. The goal of my surgery is to not only remove polyps, but every little bit of allergic mucin. And Larry Borish, who's a very respected allergist at National Jewish, talks about surgical IL-5ectomies. For the residents here, IL-5 is a really, really bad cytokine which drives eosinophils. It's a bad cytokine for rhinologists. It's a good cytokine otherwise. But when it's overactive, it draws eosinophils. And so when you remove polyps, which are rich in eosinophils and IL-5, when you remove that allergic mucin, you are actually lowering the level of IL-5 because IL-5 draws in eosinophils in there. And the cycle perpetuates even after surgery if you haven't removed every single piece of allergic mucin and flushed things out. So I spent a lot of time, and on the market now you have several, yeah, isn't that fun? All of us like it. You know it. You know if you like rhinology, if you like snot. That's how I know my residents want to go and do more of it. So here we are taking our time, and you can see how much of that mucin is still stuck there. And this is not a case where you're going to hurry up. This is not a case where we're going to do an anterior ethmoidectomy and say, hey, you know, the frontal sinus will now drain. It's not going to work there. And this is certainly not a case for balloons, although there are papers that are published on the use of balloons in polyps. It doesn't work. So to me, ethmoidectomy is not only the key to good results in polyp patients, but also in all patients, because a good ethmoidectomy is key to good, successful endoscopic sinus surgery. If you don't remove the ethmoidal cells, here, it will lead to frontal sinus problems. If you leave ethmoidal cells here along the maxillary sinus, do not remove an infraorbital or hollow cell, you're going to have residual maxillary sinus problems. If you don't remove the ethmoidal cells, surprise, you'll have persistent ethmoidal sinus problems. And if you scar down ethmoidal cells back here, you may actually lead to iatrogenic sphenoid sinus problems as well. So a lot of scar tissue will form there and cause problems. So a clean ethmoidal skull base, like I showed you in the last lecture as well, and a clean lamina papyracea are critical. This is the sphenoid sinus. You can see the optic nerve bulging in there. As you can see, everything was very expanded, and we're taking our time and cleaning things up. That's the optical carotid recess, and it's a highly pneumatized clinoidal process for the residents. That's good anatomy, see? Now, where do you think my blood pressure was at that time? So this is when I say I need a raise at Mayo Clinic, and we are in a salary structure. But you got to do good by a patient and not hurt them and do a thorough job. And remove all the subtations along the lamina papyracea carefully. I also like this, you see the middle turbinate and how it goes over, so that's a good landmark for your oblique basal lamella. So now I'm doing frontal dissection. Organese has been opened up, cap has been identified, more allergic mucin. Now we've flushed that out. Now we're identifying the frontal recess. We had a lot of that talk going on, so I'm going to jump forward in the interest of time. And there we are, irrigating, and the last 20 minutes are the longest 20 minutes because I just want to get done And I spend a lot of time making sure that I'm clean medially, I'm clean laterally. So this is just all the debris are removed, all the bone chips are removed, and then this is the maxillary sinus. I've left the middle turbinate, actually. I didn't think that it was disease. It was not polypoid. I'm finishing up. What I will do with the middle turbinate is very deliberate. I'll actually suture medialize it. And this is her. And this video is old. I just saw, I'll be seeing her again. And it's almost 3 years out. This is it. If you recognize that optic nerve, optical carotid recess, and all the way up, clean. And I've treated her with prednisone probably about once, and she is very good and diligent with budesonide. I'm not saying every patient of yours will look like that, but I'm just saying it is possible, and you don't need to do a modified Lothrop to get there. Okay. So the other thing I want to talk about is iatrogenic recalcitrance, which is basically something that none of us likes to talk about and publish about, is what our colleagues are doing with patients that can cause recalcitrance. And so if you have a patient with incomplete ethmoidectomy, I'm pretty certain recurrence will be earlier than if they had a complete ethmoidectomy. And just to reiterate what I just talked about, there's persistent osteitis here. There's a lot of scar tissue that has built up, and it has led to an early recurrence. I don't know if this was truly a biologically recalcitrant disease or an iatrogenic recalcitrance, and I struggle with that. Modified Lothrops and megaanastrostomies are good for recalcitrant disease processes. I don't always do them at the outset. I certainly have a large segment of referred patients that have horrible anatomy, horrible disease, and drill outs are done. And in the select patient, they are really, really useful. And the reason I say that is these patients have lost the ability to clear the sinuses spontaneously. They are crippled. The mucociliary lining is scarred or stripped off. And in these patients, the goal is to actually facilitate gravitational clearance. I know it's not going to recover function again, so I just want them to have large holes through which, they can ventilate well. When they irrigate, the irrigant will penetrate into the sinus well. And when they come into the office with a flare-up, I can take a big suction and actually clean it out really nicely. So, and then I don't always use these, and I have no conflicts of interest related to this, but this drug-eluting stent actually is really helpful to put mucosal flaps in. Prior to that, I would just use a celastic stent that I would fold and leave it in there. So again, this is again a topic that's not talked about when we talk about endoscopic sinus surgery, but this is important because this is the way you should finish up. We have to be intentional. If I decide to take the middle turbinate, which I will in rare situations where it's diseased or unstable, then I will do it at the end of the case, not at the beginning of the case. It's my friend, it's my landmark, it keeps me away from trouble. If I can't see, I do a septoplasty, I decongest the mucosa. I try to maintain the integrity until I decide to take it off. I resect minimally only in select cases, and in all cases I suture medialize. And I find that pathway, that wide corridor into the ethmoid is very helpful for my patients in getting topical irrigations in there. So I'll paraphrase what Dr. Wong said. In the ICAR document, endotypes exist. Mixed inflammatory clusters are likely common and important and may limit the beneficial effects of targeting any inflammatory mediators such as Ig or IL-5 in isolation. And as I was putting these slides together, I mean, these were the words of an oracle, as Dr. Wong usually is. I just had to agree with him. I don't think that biologics will be the panacea. Those of us who think we're going to do this and that and then we're going to put them on biologics, it's not going to work because this is a patient I just saw, and I don't have to read through the notes, but essentially she had been put on omalizumab, and then she was put on an anti-IL-5, and now she has received 2 infusions of dupilumab, which is anti-IL-4 and IL-13, and this is what she looks like, and she's miserable, her asthma is horrible, and she's just not had good surgery. So there is no substitute to surgery, and there is no substitute to good medical treatment. And in And I think in the future, what we have to really do is be very mindful of delivering the right treatment to the right patient every time at the right time. And this is from President Obama's Precision Medicine Initiative, and that actually helped fund our Center for Individualized Medicine that gave us some grants that I was able to use to work on some of the projects I'll share with. And this is just hot off the press from Jackie. My goal and our goal for this was to actually look at biomarkers that we could share widely, that could be commercialized or commercially available. And we looked at a biomarker called eosinophil peroxidase. And then we also looked at GATA3 and TBET. These are master regulators of Th1 and Th2 pathways. What we found was that eosinophil peroxidase, if you use it on sinonasal tissue, is able to identify high eosinophil activities very well. What we're really hoping to do is to see if the association and the ratio of GATA3 and TBET would help us sort of subtype them further, would work. It really didn't work. It didn't appear that we found any significant differences. So this was 67 subjects, and I think that we probably need more subjects to make sure that we don't have a beta error there. Some of the work we've done is also related to the microbiome and looking at potential probiotic therapy. This is the landmark article from Abreu et al. That found that there was actually a collapse in the microbial diversity in chronic sinusitis patients. We looked at sinusitis patients, controls, and allergic rhinitis patients, and we wanted to see what local changes were happening. So we swapped both the inferior meatus, which we thought was not related to sinus drainage pathways, and the middle meatus. And what was interesting is in the patients that had CRS without polyps, we actually noted that there was less diversity in the middle meatus than in the inferior meatus. So there was a very local change. And this was absent in controls. In the controls, everything was very similar, inferior, middle meatus, similar in CRS with nasal polyp patients. So probably there's a more systemic response, a genetic predisposition that is more relevant to polyp patients, maybe a local inflammatory response more likely to work in CRS without nasal polyp patients. And so please don't share this with anyone because I'm working very hard to get the first paper out on this. But I think that, as we know, most of a CRS is not a Mendelian disorder that is due to one genetic mutation, would be, as a CF or primary ciliary dyskinesia. I think there are certain changes that occur. And this paper from Utah, from a large database in Utah, showed that in patients that have CRS without polyps, their spouses had a twofold increase of that risk. So there is something environmental. I don't think in Utah, people are marrying first degree or second degree relatives. In CRS with polyp patients, however, you can see that there's an increased reporting of 4 times in first degree relatives and about 3 times in second degree relatives. And again, as people probably, close related relatives probably live together, there's also 2.4-fold increase in patients of CRS without nasal polyp patients. So I think that, the environment and its interaction with your genome has an important ramification in whether you'll have CRS or not. And so what is epigenetic modification? We all have a genome, but we have histones and other proteins and methylation of those genes that happen. And that methylation pattern changes, and it can change in me, and I could pass it on to my progeny. So there is not an identifiable mutation, but this is a heritable change that happens due to a reaction to your environment. We don't know whether it's antibiotics, we don't know if it's smoking, whether it's lack of any bacterial infections, but that happens. And in certain subtypes, we certainly know that there are epigenomic differences that have been identified. So finally, in my last couple of moments, this is actually, I lucked out. I was at the Grand Canyon and I saw a double rainbow. As you can see, I've been selling Arizona to you all. Come and visit. We live in a beautiful state. Thoughtful research is necessary to further understand CRS, and there's no single therapy that will fit all of our CRS patients, so we have to customize care so as to improve outcomes. At least we make the effort, and as we do that, maybe we will push the envelope and make significant changes to the care of our patients. So this is a course that we put on every year all the rhinologists in the room, Dr. Patel, Dr. Nayak, Dr. Wong have graced and had been part of the faculty. I'd love for you to come join us at some point of time, and if we have time for questions, I'm done.
Very good. That was an exquisite talk. What about IgA deficiency? Has that been investigated?
Yes, it has been, but unfortunately, there's no treatment for it. And there will be some patients that you'll identify that, and you'll just, those are probably, that's a really good question. Those are probably good patients where if they're having recurrent infections, probably going and creating megaantrostomies and modified low throat sphenoid sinus drill outs might be helpful in these patients. Dr. Patel.
Thank you so much, Devyani, for that amazing talk. I agree, it was wonderful. So I think most of us do start directing testing and things like that in our patients who don't seem to do as well as the majority. And you started out this talk sort of showing the high cost that CRS has in our society as a whole, and there's a cost to testing also. Have you looked at all at the balance there? Like, where do we get the cost benefit ratio that makes sense?
So I wish I had a research coordinator and we could prospectively enroll every patient, and it's very costly to do that. And so I think when insurance companies look at this data, they'll be looking at what is your revision surgery rate? How many times did you do a debridement in this patient? So I got my Medicare utilization data, and I looked at the number of visits or whatever debridement procedures that I did for these patients, and I was in a higher percentile. I only do 2 or 3 debridements. Some people report, I think the average someone said was 6 to 8. But the cost to Medicare, I was on the 10th percentile. So yes, insurance companies look at that, and that's why I don't get a whole lot of pushback. I think I'm on the preferred provider list of United. It's not easy to get on, So, and I didn't do anything with that. So yes, there is an economic cost, and yes, we shouldn't be deploying stupid tests that we're never going to use just because we want to order them. It should be thoughtful. And I think if you know a little bit more at the outset, you may be able to improve the utilization of healthcare, improve the asthma. We don't have data from our patients, but we know that if you, especially for patients with asthma, bronchiectasis, et cetera, if you improve the sinuses, then they'll have a better outcome with the lower respiratory pathology. Dr. Nayak?
So, Devyani, congratulations also on your, your burgeoning research program. It's really kind of continues to evolve, and it's great to see what you're doing there. So I'm just curious how, with the type of complex patients that you're going to get at Mayo Clinic and a place like here, Cleveland Clinic, whatever, how you're balancing the immunotherapies. Is that with, do you do it on your own? Do the allergists really help you with that? Is there, a lot of patients have already had surgeries. How do you balance that aspect of it? And are there a lot of scorpions?
Yeah, so one thing I did was to reach out to my allergists, and we actually did we do a combined clinic. It used to be every week, but now we do it every month, and it's called the Challenging Sinus Disease Clinic. And the reason we do it less frequently is both of us learn from each other. Matt Rank can do diagnostic endoscopies, and I know how to work up the basics. And if they are clear, then that's fine. If there's anything to be done, we send them to our allergy immunology colleagues. So we have a very close relationship, and all of those papers I presented, they're co-authors, and they have a high interest in CRS. I think it's about engaging colleagues, engaging pathologists. Anytime I get a report that has chronic sinusitis, I write to them. I said, hey, if you let me know how this patient is, it'll help me determine how this, what treatment I'm going to put this patient on. They like it because it impacts patient care. They don't want to fund our research for free. But it literally takes them 5 minutes to do it if they do it enough number of times.
Very good.
Thank you so much.
Thank you for the honor.